Okay, we'll make a start. So thanks everyone for coming this evening. This is the first episode of our Presenting Complaint series from the ED subsection of Mind the Bleep. My name is Eloise. I'm the one of the co-leads for the EM part of Mind the Bleep. And we're very grateful that everyone has signed up to come today. I'm very excited to present our speaker this evening. He is Dr Jack Almy, who is ST6 at the Royal London Hospital in Whitechapel. And this evening he's going to be presenting a talk on managing the initial presenting complaint of chest pain. I will be monitoring the chat, and we've got a few polls coming through as well from Jack, so do participate in those, ask some questions, and we can either address questions as we go along or we can save them up and ask them at the end. So without further ado, I'll hand over to Jack, and yeah, enjoy everyone. Thanks for coming.
All right, thank you very much, Eloise, for the introduction. Yeah, my name's Jack Almy. I'm an ST6 in emergency medicine at the Royal London in Whitechapel, and I've got an MSc in resuscitation and emergency medicine from QMUL, and I'm very happy to be here, and hopefully we have a good session. So the first question really is, why have a lecture on chest pain? And it's mostly because chest pain is really common. It's 5% of all ED attendances. And actually, with the advent of advanced nurses seeing many more injuries and lots of patients going to urgent treatment centres, seeing GPs, actually, when you work in ED, seeing undifferentiated chest pain feels like a lot more than 5% of your workload. And it's got a broad differential from fairly benign causes to those which are life-threatening and quickly life-threatening, within minutes to hours if missed. There's no one algorithm for chest pain. If you look online, you'll find attempts at making a very long, complex algorithm to manage any patient that might come in with chest pain, but it's just not really feasible. So actually, a core part of working in ED is sort of robustly identifying and treating that minority that do have serious pathology, while avoiding unnecessary investigations and admission for the majority who won't have serious pathology. And this lecture is aimed at sort of F1, F2, JCF, SHO level doctors, either about to start an ED or already working in ED, wanting to improve their skills. By the nature of how much time we've got and how broad the topic is, we can't do a deep dive into every pathology that might give you chest pain. But hopefully we can do a sort of pragmatic approach of what do I actually do as a reg, or what does an ED consultant do day in, day out when they're assessing these patients, and a few tips and tricks. But please do ask questions as we go along, and I will do my best to answer them. So what's the role of the resident doctor in assessing a patient with chest pain? So really I put it down into 5 steps. The first is to take an appropriately detailed history, which is fairly obvious, then to examine the patient, form a differential diagnosis, get the right investigations to rule out the life-threatening, and then make a diagnosis or not, which we'll come on to. And really the change in thinking as you move sort of into independent practice in ED is away from the sort of med student approach of just getting all the questions in the history and the examination, and actually trying to build a pre-test probability to say what are the potential diagnoses, but more importantly, what are the emergencies which I have to rule out, and how can I confidently rule them out so that I can sleep comfortably at night knowing that I haven't sent home someone that has had an MI and he's going to come back in arrest. And that process takes a lot of time to perfect, and definitely I haven't perfected it, but it's getting easier as time goes on. You can look up a table or a big chart of differential of chest pain. It can be extremely detailed, and in a way not that helpful to try and learn. Sorry, I've just lost my camera there. And they're extremely broad, and obviously we can't cover every cause of chest pain. But what you need to know is those which are life-threatening causes which can't be missed. And I've just put this table that I put together of diagnoses that I commonly would think of. And if you look at the left-hand side, that column there of life-threatening causes, you need to be thinking about in just about every patient, and we'll be going through all of them in the lecture today. And even if you don't end up having to specifically investigate to rule them out, you want to make sure they've crossed your mind in every patient that you're seeing with chest pain. And this differs really from specialty medicine, where as they see patients in clinics or on the wards, they might build up an increasingly complex layers of investigation until they finally get the right diagnosis. Here, we're building up increasingly complex investigations, but it's to rule out these dangerous emergencies. So if they can be ruled out with our clinical judgment or with a scoring system, then we can leave it at that. If they need blood tests, ECG, CTs, and more complex investigations, then we'll do those. But the ultimate aim is to be ruling out those emergencies that are life-threatening. And if we get the right diagnosis along the way, then that's obviously a benefit, but it's not always possible in ED. And just sort of shown in a picture there, obviously we've got 5 or 6 life-threatening diagnoses which all of us will know and want to be sure that we've ruled out. Some of those you're not going to miss, and no one would miss, because by nature of the pathology, the patient's always going to be really unwell. But we know that some of them can be quite subtle. At the time you're seeing the patient, they might not be acutely unwell, such as with a PE, even a dissection or an acute MI. And so those are the ones that we're particularly going to focus on today. So I said it's 5 steps. So history is our first step. I'm not going to overly discuss unstable patients, because actually they, in some ways, don't cause such a diagnostic dilemma. The pre-test probability is really high for serious pathology. We know something is wrong if they're hypotensive in respiratory distress, and they're unlikely to be missed. So obviously they should go into resus, they should get a cardiac monitor on, we should be looking at sort of ABC examination and supplemental oxygen. I'm a big advocate for point of care ultrasound, although we won't get to talk about it much this evening. And then you want to assess for those life-threatening causes. But the vast majority of patients, and we're going to focus on today, is the patients who are stable, that may take a bit more work to work out if they're genuinely having an emergency cause of their chest pain, and how we can do that. And I don't want to patronize you by teaching you how to take a history, because everyone knows how. But I want to emphasize the point that a detailed history in chest pain is genuinely really useful and genuinely can lead us to getting the right diagnosis and knowing what tests we need to do. So I'll go through a few points on the history, and I'll use the Socrates mnemonic just because it's helpful to lay it out like that, but I wouldn't really expect people to document it in that order. So sight is obviously essential, and the bigger thing with sight is not so much where they're pointing, but it's whether or not can a patient point with one finger specifically to where that pain's coming from. And if so, that suggests it's more likely to be a somatic type of pain. Those are, if you remember a very brief bit of sort of physiology, those are the pain receptors that are in skin and muscle pleura, pericardium. They cause a sharp, very localized pain that you know where it's coming from, often pleuritic, because that is being stimulated during respiration. That's very different to visceral kind of pain, which is a pain receptors within organs and blood vessels which sense stretch and they sense tissue damage. So it's a dull, vague type of pain, often described as a pressure. You can see that redness across the top of the chest on the photo on the right. That's a visceral kind of pain. And that's a really important question to try and localize in your mind where this pain might be coming from. And other things about the site are whether it's migrating over time. We always think about dissection if pain is moving from the chest down into the abdomen. And less importantly, but dermatomal pain that's not crossing the midline, you might think about shingles. Onset is obviously really important. Sudden onset pain will make you think of aortic dissection, pneumothorax, PE, or musculoskeletal pain. So again, still doesn't differentiate between severe and life-threatening causes and benign causes, but can give you a clue to where that pain's coming from. I'd always ask people what they were doing at the time, not because there's necessarily a link between the two, but if they can remember exactly where they were and what they were doing at that moment the pain began, it's a bit more convincing that it genuinely was a sudden onset pain, rather than a patient saying, yeah, I think it was sudden onset last week, but not really remembering that moment. Doesn't sound like a sudden onset pain to me. If it builds up over a few minutes, particularly with exertion, of course, you're thinking of ischemic pain. And if they're having recurrent episodes of pain, then you want to look at what is triggering that. Is it triggered after meals, for example? You may think of reflux, or is it triggered by exertion? And again, you might think of ischemic pain. And the character of the pain is useful, of course. So we've said already that visceral pain is that dull pressure, tightness, could be described as constricting, or at its worst, sort of crushing pain. Whereas the somatic pain coming from muscles and the pleura is sharp or stabbing. We know that what descriptive words patients use on big observational data, it does increase or decrease your likelihood ratio of it being cardiac, but no one word has been found to be adequate to rule out ACS or to rule out cardiac chest pain. So I'd never comfortably say, oh, well, he said it's a sharp pain, therefore we know it's not an MI. And we'll come on to how you can more conclusively rule out cardiac chest pain and emergency causes of chest pain rather than just on the history. But it's obviously helpful to hear how it's described and start to make that image in your mind of what type of pain they're picturing. Tearing is classically the word used in dissection pain. And it's really important that we get through the language barrier with these patients. Depending on where you work, I'm in East London, and a lot of patients don't have English as their first language, and getting a sort of muddled history with only simple words for pain that can't really describe the nuance of the pain is really not helpful for us to actually get the right diagnosis. So you need some sort of software to interpret what your patient's saying. So do take the time to go and do it. Don't just rely on family. I know it's a cliche that you get told throughout med school, but genuinely it is really important to take the extra time to really understand what descriptive words they're using with that pain. Radiation comes on with this visceral type of pain again. So I work in ED, so I'm not big on understanding detailed physiology, but the picture there just showing the fact that visceral pain receptors enter the spinal cord at the same level as the somatic pain receptor, and then they both synapse with a secondary neuron. So if you're getting pain from your ischemia in your heart muscle, you may feel that in the area supplied by the somatic nerve. So we know that heart pain, cardiac pain radiates to the arms, to the jaw, to the back, to the jaw and to the neck. Can also be felt in the epigastrium as well. So that kind of diffuse radiating pain, it's obviously high suspicion of ischemia. Radiation to the back is characteristic of dissection, but can also be felt in pericarditis and gastroesophageal reflux. So it's not by itself extremely sensitive, extremely specific for dissection, but it is sensitive. Most patients will have it radiating to the back, but it doesn't mean that it definitely is dissection just because they're saying that. Pain that's radiating up from the epigastrium, we saw in the table earlier, there's a number of sort of GI causes of chest pain. So you might think of reflux disease, peptic ulcer disease, biliary colic, pancreatitis can all be coming from the abdomen radiating up into the chest. But MSK pain shouldn't really be radiating. We should be sort of questioning ourselves a bit if we think it's a muscular strain that's sort of radiating to different parts of the chest. And associated symptoms, again, this is just fleshing out that patient's history. You could write a much longer list than this, just a few things that are immediately come to mind. So we know that cardiac chest pain is associated with sweats and nausea. So those are both worrying symptoms if they come with the pain. Difficulty breathing might suggest PE, but also lung pathology, whether it's viral, bacterial, pneumonia, exacerbation of COPD, asthma can all be causing difficulty breathing, chest pain, and a pneumothorax, obviously. Neurological symptoms you can get in dissection. Leg pain and swelling will make you think of PE if there's signs of DVT. A viral prodrome can come before an episode of myo or pericarditis. it's important to ask what was happening before this chest pain started. And a productive cough obviously makes you think of pneumonia, and hemoptysis, a PE. And the timing, anything in ED that's long-standing, I'm less worried about. So someone coming in saying, I've been having chest pain for 2 years, immediately you have a very low pretest probability of a serious cause. So that's quite reassuring. Recurrent episodes, like I said, angina or reflux disease, whether it's triggered by exertion. And if it is triggered by exertion, you want to explore how much they can how much exercise they can tolerate. Is it that they used to be able to walk a mile, now they can only walk 10 yards before that chest pain starts? And you may start to consider whether this has moved from stable angina to unstable angina. Fleeting pain, rarely from ischemia. And yeah, recent pain. Someone who's come straight to hospital with their pain always raises an index of suspicion that this is significant, as opposed to someone that's sort of sat on this for a few days or weeks and eventually decided to go and get checked out. Exacerbating factors and relieving factors, we know obviously that ischemic pain is exertional. If I could ask any chest pain questions, I think it would be those top two, differentiating, is this exertional pain, or is it the type of pain that if they take a deep breath in, there's a sharp element to it and it gets worse, that you see in PE, pleurisy from irritation of the pleura, like in infections, pneumothorax, musculoskeletal. The differential is still quite broad, but it puts it into those two quite distinct categories. Eating can make any sort of gastroesophageal cause of pain worse. Improvement with GTN is sometimes sort of held as a useful diagnostic test. Obviously, ischemic pain will get better if someone takes their GTN, but it's not a sensitive or specific test. There's a placebo effect of just taking a medicine. So knowing that a patient's pain improves with GTN doesn't specifically tell you what is causing that pain. And we know that pain that is better when you're leaning forward can happen with both pericarditis as a hallmark feature of it, and with reflux. So again, none of those can specifically differentiate between these conditions, but it will help to mold your pretest probability of what you think might be going on. And severity, lastly. Severity is not a sensitive test. It doesn't tell you for certain that someone has serious pathology. You see lots of people with really significant pain when they come in, and actually after some Gaviscon and omeprazole, things settle down. We find there was nothing really wrong. Be wary of atypical presentations in diabetics that might have minimal chest pain. Epigastric pain, for example, might be the only presenting symptom, or just feeling not quite 100%, not quite able to mobilize as much as they normally would. Yeah, definitely be wary of them. Sort of stoic older people that don't respond to pain or don't vocalize their pain in the way that some other people would. And again, pain that's controlled while a patient's at rest. So it's reassuring if someone's not in severe pain, but the absence of severe pain doesn't mean that there's nothing going on. So unstable angina is a medical emergency, but it may be that after some GTN and sitting still for 20 minutes, the patient actually is quite comfortable. That in itself doesn't mean that they're not having an emergency. So we need to really consider what it might be causing it before just being reassured by the severity of the pain. That being said, if someone's got their worst ever pain, and that's been shown to be quite a good indicator, particularly in aortic dissection, that they do have serious pathology. And it goes without saying, if a patient's in severe pain and remains in severe pain, they're going to get a more detailed investigation than someone whose pain was mild and improving. And the last bit of the history is that I'm not going to tell you sort of how to take the past medical social drug history, but what we're really trying to do here in particular is identify risk factors for three main life-threatening conditions, which we'll come on to, that being ACS, pulmonary embolism, and aortic dissection. And they need to be, if you're working in ED, particularly the cardiac risk factors, need to be things that just roll off your tongue to say, you know, I'm considering whether this person could have ischemic heart disease. Do they have diabetes, high cholesterol, hypertension, smoking, etc., family history? But we'll come on to the list, but they're the kind of lists that you should just try and commit to memory before you start or while you're working in ED. And I've just put below about making this bit of the history appropriately detailed. And I don't want it to sound, again, that I'm being sort of pedantic, but it's moving from that sort of med school model where you might fill in a whole clerking and know that you need to summarize the past medical history to genuinely understanding how it's going to shape your understanding of the patient and the way you're going to test them and investigate them. So I've just put the example. You might have someone that has ischemic heart disease coded in their past medical history, but when you do some reading and you look at an old cardiology letter and you check with the patient, is it ischemic heart disease and they've had an NSTEMI with previous PCI to their LAD, for example, which is now detailed, and you get an understanding that this person does have genuine coronary artery disease? Or did someone have ischemic heart disease coded in their history, but when you look, they've been seen once in the chest pain clinic. The impression in the clinic was it was not anginal chest pain. They've been investigated maybe with a CT, CA, and found to have no coronary disease and been discharged. And that patient might still get the label of ischemic heart disease left on their record for years to come. So it's helpful to actually do that little extra bit of a deep dive to say, why is that label on the past medical history? What does that actually mean for my patient and for their risk of developing different pathologies? And it's also really useful for when that patient gets clerked, admitted into hospital, discharged. You'll probably find that your more detailed description of their background remains in the medical notes for months and years to come, and people do rely on it. So getting it detailed there is really helpful. And I'd ask a bit about drug compliance. Again, if a patient has hypertension on 3 agents and they're not taking any of them, that's really important to know, rather than making it a sort of rote job that you should be writing down the list of a patient's medicines. What we want to really know is how does their compliance with the medicines and how does the medicines that they're on change our perception of what might be going on here. And GTN is an example of that. They might have GTN on their drug history, but are they using it all the time, more and more often, or is it sat in a cupboard and not been used for years? That's quite important to know. So we move from taking the history to examining. And I can't, again, tell you how to examine a patient, but before you go and see them, or while you're seeing them, it's definitely worth looking at their obs. And I've just made a table of some of the things that you'll think about depending on each of the patient's obs. So high blood pressure will be concerning for aortic dissection or hypertensive emergency, whereas low blood pressure in a patient with chest pain is always serious. And I don't think any of us would really miss that. A hypotensive patient coming in with chest pain should be moved to resus. They'll get a senior review, ultrasound, and you're going to immediately consider those life-threatening causes: tension pneumothorax, tamponade, cardiogenic shock, PE, etc. Looking at their pulse rate, a fast heart rate is really non-specific, but it should always sort of catch your interest, and you should try and understand why it's fast. Is it from pain and dehydration and fever, simple causes which you can treat, analgesia, antipyretics, give them some fluid? Or is it something a bit more sinister, sepsis, PE, myocarditis, arrhythmia? And so you shouldn't be discharging someone if that heart rate is still fast, unless you're really, really confident why it is quick. And it should always raise a suspicion of those more serious pathologies. And a slow heart rate may just be physiological for the patient, but you should, of course, think of a bradyarrhythmia and get an ECG, make sure they've got a normal rhythm. Increased respiratory rate is a sensitive marker if we're doing respiratory rates properly. So it can be one of the first obs to become abnormal in a patient that's unwell. So I would be wary of those patients that are always listed with a respiratory rate of 20. Check it yourself. If it's moving into the mid-20s, high 20s, then we need to look for a cause. And I'll be really wary of labeling a patient as anxious with a high respiratory rate, particularly if they don't have any history of sort of anxiety and that kind of presentation before, because we know nationwide that patients with PEs and other serious problems have been discharged told they're probably just anxious because they've got a fast heart rate and fast respiratory rate. SATs, of course, low SATs are going to make you think of pulmonary pathology, while an increased temperature will make you think of pulmonary infections primarily, but as well, there are other pathologies that can give you a fever, so myocarditis, endocarditis, and remember PEs can give you a low-grade fever as well. So the presence of a fever alone isn't enough to say, yes, I'm sure this is infectious, and I'm sure it's not a more serious pathology like a PE. And then you come on to examine the patient, and basically here, I don't have many tips and tricks. You've all been working for however many years in hospitals and doing med school and OSCEs. You just need to develop those clinical exam skills, do a full cardiovascular respiratory abdominal exam on every patient with chest pain. More importantly, though, is that general appearance. What color are they? Are they sweaty, a bit clammy? Do they look a little bit grey and ashen? Do they have prolonged cap refill? You want to develop that sixth sense of, is there just something not quite right about this patient that's going to make me go and see them first, as opposed to the one that's sitting, playing on their phone, walking around, had a coffee, went out for a cigarette. That's the sort of thing you just need to develop. You want to check if they've got signs of chronic disease, COPD, heavy smoking, assess their fluid status in everyone. So just get really used to listening to the lung bases, feeling for peripheral edema. You want to feel for chest wall tenderness, but knowing it's not, again, a specific sign of anything. So a patient could have serious pathology and also say it hurts when you press their chest. So I'd be cautious of really clinging on to saying, yes, that chest was tender, therefore I'm happy it's MSK pain. We need to do a bit more than that, which we'll come on to. I asked them to take a deep breath in, and that's again looking to see if we've got that somatic type of pleuritic pain. Always feel their legs, both for DVT and peripheral edema, and consider a neuro exam if you're thinking of dissection. Okay, so at that point, we would have done our first two steps. We've taken a history that's nice and detailed, we've examined them, and we've sort of fleshed out our understanding of what this patient's pain is and what they've come in with. And now we're trying to match that to a huge list of differentials. And we're trying to say, how similar is this picture we've got of our patient to these other textbook examples of pathologies? How similar is this to a textbook PE or ACS or dissection? And the only way of being able to do that is by really understanding and knowing about what a classic example of those conditions are, which we'll come on to. But regardless, before we start to try and rule them in and out, we should be able to make some sort of impression and some sort of differential diagnosis at this point, just from the history and exam. And I think it's one of the skills that people develop over time, and some people are quicker and happier to do it than others, is to really like put your money where your mouth is and say, okay, I've seen this patient, I think it's probably reflux, but I need to rule out ACS. Or I think this could be a PE, but it could be musculoskeletal. Or even if you're still a bit unclear, but you just say, this sounds like cardiac chest pain in a patient with lots of cardiac risk factors. It's helpful at this point to say, I've got a differential and I know what might be going on and what I need to rule out, because that's the whole point of what we're doing here. What's really unhelpful is if after the whole clerking, the plan is, or the impression is not even there, and the plan is just ECG, TROP, D-dimer, chest X-ray, discuss, because you've not particularly added your sort of medical opinion to it. It's just saying more investigations, which might give us an answer. So let's come on to the differential diagnoses that we need to understand if we're going to rule out an emergency. So acute coronary syndrome is made up of three different sort of entities. So on the left, you've got stable angina, which is a stable plaque, which gives you that cardiac chest pain when your demand goes up, like when you're exercising. Unstable angina is when the plaque ruptures and it causes some partial occlusion. You will now get worsening of that same anginal chest pain, and it may start to happen at rest. So classically, these are patients that now cannot walk as far as they used to before needing the GTN, needing to use it more and more often, and that chest pain is occurring at rest and not going away with their GTN. NSTEMI is when you've got the ruptured plaque causing occlusion of the vessel to the point that you actually get some infarction to the myocardium, and it's going to release troponin. And a STEMI is when the ruptured plaque causes complete occlusion of a vessel, and you get infarct of the whole wall of the myocardium, and that causes the ST elevation that you see on an ECG. So it's really important to understand that with ACS, you've got those 3 different pathologies going on. The risk factors, like I said, are ones that you kind of need to just learn by rote. Hypertension, high cholesterol, diabetes, smoking, obesity. We see in East London, we've got a big sort of South Asian, Indian, Bengali population. We know that they're really high risk just from their genetics of having ACS. A family history is relevant if it's a close family member under 65. It's not just a grandparent that died of a heart attack, because that's too non-specific. And if the patient themselves has a prior MI or vascular disease elsewhere, that's of course concerning. And the typical presentation is that cardiac chest pain that most of us have been taught in med school. It's visceral pain, so it's dull, it's tight, constricting, maybe central or left-sided, can radiate, and it's exertional with those associated symptoms. But we mentioned before atypical presentations, particularly in diabetics, women and the elderly. So we need to maintain a high index of suspicion. The next emergency to keep in our mind is aortic dissection. What is it? Well, it's a tear in the inner layer of the aorta, which lets blood flow in between the layers of the aortic wall, creating a false lumen, which can then dissect further down the aorta. Like I said, we're not going to do lots of physiology today, but it's just important to know that they can broadly be put into 2 categories, A and B, depending on whether the dissection is more proximal around the ascending aorta or more distal around the descending aorta, because that's going to affect the management. Risk factors for the dissection. Biggest one is uncontrolled hypertension. You can also get it with acute hypertension, like from drugs like cocaine that can put up your blood pressure. Atherosclerosis that weakens the wall of your aorta. Older men, but also younger people, like with connective tissue disorders, Marfan's, Ehlers-Danlos, abnormal aortas because of a bicuspid valve, coarctations, aneurysms. You can have it after trauma, and it can be iatrogenic after operations, heart surgery, etc. And you're more likely to get it in pregnancy as well. So there's no one typical patient for dissection, but if you had to choose one, it's going to be an older man with hypertension and atherosclerotic disease. The presentation is fairly typical, which is that sudden onset pain, severe and maximal onset. So it goes from nothing to severe pain very quickly, central chest pain going into the back, and can then migrate over time down into the abdomen. Patients can have a pulse deficit, so it's considered significant if it's more than 20 millimeters mercury between the left and the right arm. They're normally hypertensive when they come in. It's more concerning if they're hypotensive with a dissection, but they can be, particularly in a type A dissection that's affecting your cardiac output. They can, like I said, get focal neurology, and they can get a new murmur as their aortic valve becomes incompetent and they get aortic regurg. Next emergency we'll look at PE. Again, we all know this. What is it? It's an emboli, one or more, that comes normally from deep veins elsewhere, goes through the right side of your heart, and it's lodged in your pulmonary artery and obstructs it, causing severe respiratory dysfunction. The risk factors for a PE, I've listed them there from strongest to weakest. So not all of these are always mentioned in a clerking or thought about. I think most of us know that recent surgery and previous VTE is a high risk feature. Weirdly, it seems people always focus on air travel as the biggest thing, whether someone's had a short flight in the last few months as being the big risk. It's been shown on sort of observational data, it doesn't really correlate particularly well with patients having a PE, but it is still a risk factor there. But the big ones to learn are near the top there: surgery, malignancy, pregnancy in the estrogen-containing pills, paralysis or thrombophilia for any reason. And a typical presentation for PE is that sharp localized pleuritic pain, sudden onset with breathlessness. They might be hypoxic, may have some hemoptysis, with signs of a DVT, and they may be tachycardic and hypoxic when you examine them. It's important to remember that they can have other findings that don't sound like a PE, so they can have some wheeze, they can have a low-grade fever. So the presence of either of them doesn't rule out a PE. And a massive central PE might present with many more sort of cardiovascular features, bradycardia, syncope, rather than the chest pain, which only really happens once you get necrosis of the lung tissue near the pleura, so in the peripheries. So a central PE can actually cause, as I say, cardiovascular symptoms and not the classic pulmonary symptoms early on. And I won't say much about tamponade and aortic and Boerhaave syndrome, only because they're fairly rare and they're fairly unlikely to be missed. So tamponade is compression of the heart from a pericardial effusion causing an obstructive shock. You can get it with malignancy, pericarditis. It can be after heart surgery, and the other risk factors there. And classically, it causes this Beck's triad of low blood pressure, muffled heart sounds, and raised JVP. I don't think many of us will pick that up clinically, but more importantly, the patient's going to be hypotensive. They'll be assessed in resus, and the investigations in early echo, which isn't one that there's a lot of diagnostic nuance about, because no one's going to be sending home these patients. And the same can be said for tension pneumothorax. So it is an emergency cause, but it's not kind of the bread and butter of working in ED. It's air within the pleural space, as you know, now compressing the mediastinum and causing hypotension as well as pleuritic chest pain and respiratory distress. Risk factors there we should know about, but we're not going to be missing tension pneumothoraces because patients are really unwell when they've got one. The treatment is obviously needle decompression, but again, it's not something which there's a lot of nuance and difficulty making the diagnosis, and we're not going to be sending home these patients and losing sleep at night about whether we've missed something. And esophageal perforation is one just to keep in mind with anyone that's either had medical procedures on their esophagus, or they've got severe chest pain after vomiting that's persistent, is when you get a tear in the wall of your esophagus and food and stomach acid, etc., leaks into the chest cavity. It starts with severe chest pain that's worse on swallowing, but can then develop into fever and mediastinitis. And these patients need to go to ITU. They can be really unwell. So by understanding those classic pictures of what the life-threatening pathology is, we can then start to say, well, how similar is my patient to any of them? And how similar actually is my patient to some of these less urgent pathologies that I've listed on the right? I mean, I put them as less urgent, but I say it with a pinch of salt. Obviously, any of those can become more urgent. Pneumonia can be urgent if the patient's, got respiratory failure. But classically, those ones on the left-hand column are the life-threatening emergencies that we need to consider. And we need to say, how confident am I that my patient doesn't have these things? And what steps do I need to take to confidently rule them out? So we come on to step 4. We've got our differential. We might say this patient with cardiac sounding chest pain, is it cardiac or is it just reflux? Or this patient with pleuritic pain, is it PE or is it musculoskeletal? And then we need to get the right investigations to rule out those life-threatening diagnoses. And really, I'm going to focus on just 3 of those, which is ACS, PE, and dissection. Because like I say, those are the ones which the patient might not be sort of critically unwell. They might not be hypotensive, and we might be thinking about sending them home. And we need to know that we've not missed something when we send them home. And the stepwise, not so much stepwise, but the approach we use is to get the right investigation and the least invasive investigation to confidently rule it out. So that might just be your clinical opinion. You might say this pain in a young person with no past medical history doesn't radiate into the back. There's no they've got no blood pressure differential. It's not severe. It's intermittent. I'm happy. It doesn't sound anything like a dissection. You don't need to write a long spiel to say that, but it's worth just knowing that in your mind, that you've considered that emergency and by knowing what the classic picture of a dissection is, you know that your patient is so different from that, you don't need to move any further. Then it may be that you want to put something a bit more objective to it. So you might want to say, I don't think my patient has a PE, but I'm going to apply the PERC score to actually put a number to it. And we'll come on to what that is. And then we may do more simple bedside tests. So ECG for everyone, D-dimers and troponin when it's indicated, chest x-rays, point of care ultrasound, and CT are the mainstay of our sort of ED investigations that we've got. So let's go through how we're going to rule them out. So a STEMI is one of our 3 ACS. ACS is an umbrella term, and STEMI is one of the 3. And it's important to know STEMI is diagnosed on the ECG as opposed to the TROP. So we're actually on the 4th definition of what an MI is, if anyone's interested. There's a big document from Society of Cardiology. And the definition of a STEMI is written on the left there. So it's ST elevation at the J point, which is that point as you move from the S wave into the ST segment. It's ST elevation at the J point in 2 leads next to each other, contiguous leads more than a millimeter, apart from in V2, V3, where there's different cutoffs. So you're allowed to have more ST elevation in V2, V3, particularly in men and particularly in younger men. So the ECG below us there shows an anterior STEMI. And you can see as well, there's some reciprocal changes in the inferior leads there on the left. I think I've got a picture. That's something that is worth knowing and learning for starting an ED, if it's not already kind of comfortably in your mind, is just knowing what the territories are, what coronary artery supplies which territory. We can't obviously go through an ECG interpretation today, but it's important just to know it so that when you are looking at ECGs, you know, is this a regional type of ischemia? And the 2 things I'll say about STEMIs, one is be cautious with things that look like ST elevation but aren't. So benign early repolarization or high takeoff is really common. On the right there, under B, you can see this concave upsloping ST elevation, whereas on the left you've got ischemic types of ST elevation, whether they're convex, horizontal downsloping. So that type of concave ST elevation is really common in young men in V2, V3, and is typical of high takeoff. So that ECG below just shows normal. It's a normal ECG with a patient with high takeoff. And I'd also put it with the clinical symptoms. So I'm sometimes shown ECGs where people say, you know, do you think this patient's having a STEMI? But you've got to interpret that in the context. And if it's a 22-year-old who's come in with pleuritic chest pain, it's really unlikely, and, you know, sitting there really comfortably with nothing that sounds like cardiac chest pain, already it's really unlikely. And by knowing that STEMI definition in a bit more detail, then you can say, no, that's just high takeoff, that's normal. There's a number of other things that look like ST elevation or are ST elevation, but they aren't because of a blocked coronary vessel. We won't have time to teach them all, but it's another thing if we're working in ED to understand things like pericarditis causes a classic saddle-shaped ST elevation everywhere. PEs can give you ST elevation. Left ventricular hypertrophy, there's lots of them that will look like ST elevation, but they're not because of an occluded coronary artery. But you need to have even more caution with things that don't look like ST elevation, but actually are because of an occluded coronary artery. So it's another thing that is worth going away and learning is things like Welland syndrome, De Winter's, posterior STEMI that you won't see on the ECG. You'll just see the reciprocal changes in the anterior leads. It's really important because those patients that have a STEMI need immediate reperfusion. They're not patients that have time to be sort of further investigated in the ED. And you need to recognize that even though there's not ST elevation, there are these other patterns that also mean that a patient's got a blocked coronary and needs to go to the heart attack center. Because that is the treatment, essentially. We'll move them to resus. We will give them dual antiplatelets and morphine and antiemetics. But ultimately, if they've got a blocked coronary, which is a STEMI, they need to get to the heart attack center and they need to get PCI. So it's really important that we can diagnose STEMIs on the ECG. NSTEMIs are really variable. The ECG can show anything from ST depression, T-wave inversion, biphasic, weird-looking T-waves or Q-waves, or may just look normal. So it encompasses loads of different types of patients with varying degrees of ischemia. And like I said, if they've got regional ST depression, like in the anterior leads, you've got to consider, is there actually ST elevation elsewhere, and have a good hunt for it. It's a good rule of thumb that if a patient does have some ischemia on their ECG, get a repeat in 20 minutes, because a dynamic change is a high risk feature that something is going on now in their coronaries. It's not just a static ECG, and they always have some ischemic changes which are normal for them. NSTEMIs, unlike STEMIs, are ruled out with troponins, not on the ECG. So wherever you work, you'll have different guidelines, but you should look at them and know them. Broadly, troponin is a protein released from myocytes when they die. So they show that you've got some necrosis and ischemia of your cardiac myocytes. It takes a couple of hours for it to rise, so it's not a sensitive test when they immediately arrive in the department. Most protocols need a trop at 3 hours to rule out an NSTEMI. And if it's negative at 3 hours, that's fairly sensitive to rule out an NSTEMI. For some patients with a chronically raised troponin, like in heart failure or cardiomyopathy or kidney disease, you want to check 3 hours apart and see if there's a change between the two. It shouldn't change by more than 20% in 3 hours. If it does, that's a sign that there's a coronary event, that ACS is happening. And this is just a picture from, well, it's actually our old BARTS protocol, where we risk stratify the patient for how likely we think ACS is into low, moderate, and high, keeping in mind that low risk, some patients don't need TROPs. If they're a young patient, under 33 is our current guideline, with no cardiac risk factors, and it doesn't sound like cardiac chest pain, they don't need a TROP. But the majority of patients do, and the majority of patients will get one on arrival and one 3 hours later. And this is just the rule-out regime that we had been using until recently. And you can see that most patients that are moderate or high risk, so have some cardiac risk factors, you want to get a 3 hour trop. So it definitely would have risen by then if they're having an NSTEMI. And if it's negative, then you've ruled out. Treatment for an NSTEMI: aspirin, dual antiplatelets, aspirin and clopidogrel, add in fondaparinux, which is a 10A inhibitor, GTN as a spray, and then a GTN infusion if they still have pain. And the majority of these still need discussion with cardiology, because if they've got high risk ECG features or they've still got ongoing pain, then they may well go across to have PCI, a bit like a STEMI. Otherwise, they'll have an angio within 72 hours and come in under the medics. And the last in the sort of ACS umbrella is unstable angina, which is really important to think about because it is ruled out on the history entirely. So the ECG might have some ischemic changes, but the TROP will be negative because, like we said, unstable angina, there's plaque rupture, but you're still getting flow through your coronaries. So the classic story is that anginal chest pain that's provoked by less and less exertion. Now it's at rest. Now the GTN's not helping. Those patients need admission and treated as a STEMI, reviewing by cardiology, and they probably need to get an angio as well. So STEMI is ruled out in the ECG. NSTEMI is on your department's troponin protocol. And unstable angina, you've then got to think about, and you've got to rule it out based on that history. And once it's ruled out, and assuming you've ruled out other causes, if purely ACS was on your differential, you've ruled it out. What most places will do is to look at a heart score, which takes into account the patient's history, ECG, their age, their risk factors, and their TROP, and gives you a score that will decide whether there's enough of a risk that this patient needs seeing by a cardiologist, and they would be referred to a chest pain clinic, or if the score is low, so less than 4, they'll just be seen by their GP. Now I'll move swiftly on because I'm aware of time. PEs is the second of the 3 big emergencies we want to rule out. If you've got a low suspicion, I'd encourage everyone to look at the PERC score if you haven't seen it already. So it's basically a big trial that showed that if patients have none of these criteria, they are so unlikely to have a PE that you don't need to do any more investigations. So young patients who aren't tachycardic or hypoxic and don't have those risk factors you can see, you can stop there and say, I'm happy it's not a PE. So that's definitely one to learn and to use. If they have any of those criteria, then they need testing. And the testing we do is the Wells score, which you've probably used or seen in the past. So you calculate the Wells score from the criteria shown. And depending on the score, if it's less than 4, so you have a low clinical suspicion of a PE, then you can use a D-dimer. And if the D-dimer is negative, you've ruled out a PE. If it's positive, then you progress to a CTPA. Whereas if you've got a score of 4.5 or more, then they go straight to a CTPA. D-dimer is not sensitive enough to rule out a PE, and you go straight to the scan. And you can probably see on the right there, that scan showing a saddle embolus sitting across the pulmonary artery. So a few little points on D-dimers. So we know it's really sensitive. If you've got a PE, it will almost certainly show it, although it's worth saying it can become negative a couple of weeks after the PE happens, just to keep it in mind because it falls over time. It's really non-specific, so all types of other conditions from infections and cancers and surgery can make your D-dimer rise. And it rises with age. So another thing to definitely take away and use is the age-adjusted D-dimer. You can use a calculator online that will show you your patient's age-adjusted D-dimer, and it's been accepted by NICE that we can use it, and it will basically allow you to tolerate a higher D-dimer for your patient, a higher D-dimer threshold to do a CTPA. So basically increases how specific the test is, but it's still just as sensitive. So if that patient has got a PE, that new cutoff, the new age-adjusted cutoff will find it. And if they don't have a PE, then you can stop there and not do a scan. So it's really important, really useful. ABGs, I use less and less. The patient might be alkalotic or hypoxic, but it's not sensitive enough to rule anything out. Like I say, a central PE might not be affecting your ventilation and might not actually change your oxygenation much. So you don't need an ABG as part of a PE workup. ECG, as you probably know, is not a specific test in PEs. The most common finding is a sinus tachy, but you might have some right ventricular strain, so changes, T-wave inversion in sort of V1 to V3. And occasionally you'll see this S1, Q3, T3 pattern, which you've got on the right there. So a deep S wave in lead 1, a Q wave and T-wave inversion in lead 3. The chest X-ray we should do as our first step in investigating a PE, just to see if there's other pathology causing the problems. But it's likely to be normal unless there's some pulmonary infarction, which can cause a sort of wedge-shaped abnormality. And point-of-care ultrasound, which I'm a big fan of, is not used in our diagnostic workup, but it might help or will help to kind of risk stratify that PE by looking at the right ventricle. There's a few different signs which are sensitive for PE. And I'd encourage anyone working in ED to go on an ultrasound course or find your ultrasound enthusiast in the department and see if you can start learning to do echoes, because it's surprisingly simple once you've done a few times. If you diagnose a PE, they will normally be managed by the medics, but it's worth knowing about the PESI score, which takes in a few predictors of things which are associated with an increased mortality. And then PEs are now stratified into high, intermediate, and low risk. The high risk ones are ones where the PE is so big that it's causing sort of cardiovascular effects, so shock or hypotension. The intermediate ones are ones where there's no hypotension, but the patient does have a high PESI score and signs of dysfunction in their right ventricle and raised biomarkers. So a raised troponin you can get, that would make it an intermediate risk. And low risk is a low PESI score, no raised trop, and no signs of RV dysfunction. And the treatment there, as you can see, these days it's a DOAC, so a direct anticoagulant, and usually they're managed by medics in a sort of outpatient ambulatory setting. If it's intermediate risk, so there's some right ventricular dysfunction or raised trop, then you may give some half-dose thrombolysis, as in clot-busting alteplase. And those high-risk patients we know should all get alteplase. And now your hospital might have something called a sort of PE response team, or which includes interventional radiology to use some other techniques with catheters to break down the clot. But you wouldn't be managing that kind of decision by yourself. That's a fairly team effort and a fairly rare pathology to have a high-risk PE. And the last pathology which we need to think about and rule out is dissection. So we know that ECGs are fairly non-specific for dissection. It might mimic some ischemia, or it can even cause an MI if it's dissected back to the right coronary. Chest X-ray people will talk about. We know you can get a widened mediastinum, but it's not a rule-out test if it's normal. And ultrasound, again, you may see something which suggests a dissection, so a dilated aortic root or a dissection flap. That's great if you see it because you've made the diagnosis right then and there, but none of that will rule it out. It's all on the history. And if the history is high, let's step off that. If the history is high, they just need to go for a CT angio, which is a contrast scan of the aorta, which will show a dissection. This risk score can be used only in patients where you've got a really low clinical suspicion to start with. If they only have one or none of these features and they've got a negative D-dimer, then you can rule out a dissection without needing a CTA. But the majority of patients, once they've got some of the signs and you're starting to think dissection is a possibility, they just need to go and have a CT angio. And the picture there shows a dissection just in the descending aorta next to the vertebra there, just labeled in red. And the treatment in ED is supportive at first. So it's getting their pain under control and their blood pressure under control, which will help to reduce further dissection. They need to be discussed with cardiothoracics. And the type A, those are the proximal ones affecting the ascending aorta. They need to go for surgery, while the type B is medical management with blood pressure control. I'm not going to talk about investing tamponade, and I'm not going to talk about ultrasound as much as I would like to, because I'm aware we need to get on to do some cases if we have time. So hopefully I've explained that by taking a detailed history, examining the patient and making a differential, you can then rule out those three life-threatening and sometimes missed pathologies using a combination of your ECG, chest X-rays, clinical scores, and CTs when appropriate. And then the final point is you may make a diagnosis at the same time as ruling out those emergencies. You're obviously trying to find what's actually wrong with the patient. But it's okay if you haven't made a concrete diagnosis at that point. At that point, you then need to say, well, is this patient well enough to go home, or do they need admission for further investigations? And assuming the patient's well enough to go home, you can reassure them that actually they've had a fairly robust and thorough investigation to rule out emergencies, which is the main point of the emergency department. You know, we couldn't talk about the evidence here, but the combination of those scoring systems, the high sensitivity TROP, the CT angio, that's a really concrete way to know your patient doesn't have these emergencies. And I've written own the uncertainty, because you see a lot of patients just being labeled as having costochondritis, which is not that common. And I think it's actually okay to say they've got sort of unspecified chest pain at that point. They've got non-cardiac chest pain, and we haven't made a concrete diagnosis. And we can reassure them that if they take simple painkillers, give it some time, lots of the time these pains may go away, or they could be investigated appropriately, whether that's your rapid access chest pain clinic, if they've got a high heart score, SDECs, which more and more hospitals have an SDEC now, so medical SDEC might be able to investigate some patients, or depending on what pathology you've found, you know, if they've got a respiratory problem, maybe they could be worked up by community respiratory services. And obviously we're safety netting them, and if we always explain it, we're just seeing a snapshot of how they are now. If things get worse or change, they can always come back to the emergency department and we'll reassess. So, in conclusion, a detailed history is vital. Understanding that difference between visceral pain and sort of somatic sharp pain is vital in determining how likely is serious pathology. You need to have a robust process, and I've kind of noticed in the last hour, despite it all seeming fairly simple and something that we do all the time, there is a lot to it, and it will take some time if you don't already work in ED to get your head around those different processes we use. But you need to know and understand the processes that are in place to robustly rule out ACS, PEs, and dissection in particular. Don't ignore abnormal observations. So if a patient's persistently tachycardic or the respiratory rate is above normal, you really need to ask yourself why that is, and investigate more. And discuss every patient. It's an RChem standard, so that's College of Emergency Medicine. We should be discussing every patient with chest pain, atraumatic chest pain in an over 30-year-old with a reg that's ST4 or above. So come to us and make us explain our thought processes, and enjoy it. And if anyone has time in another day, I'll talk more about ultrasound. But for now, I think we've got a couple of cases. I'm aware it's 8:30. Eloise, I don't know, are you happy to go through the questions?
Yes, absolutely. So there was one that asked, do we do fast scan for AAA before ordering a CT angio?
So I suppose here we're talking about, so AAA is more likely going to give you abdominal pain if they've got a ruptured AAA. For dissection, it can be useful as a rule-in test. So if someone comes in obviously unwell with a really deranged blood pressure and severe chest pain that may be going down into the abdomen, then putting a probe on their abdomen, if you see they've got an abdominal aneurysm or they've got dissection there, you've made your diagnosis. So yes, in someone that's definitely unwell. In someone that is well and the obs are fairly normal and the history is not that specific, but they said, oh, maybe it went through to the back, and you start to ask yourself, could that be dissection? I probably wouldn't, because they're really unlikely to have significant pathology that you're going to pick up as a non-specialist. So the test there, if you're querying it, is to go for a CTA. But it's a really good question. And I'm a big fan of people putting probes on people to rule in serious stuff if you can.
Thank you, Jack. And there was just another question asking what rapid access chest pain clinic was.
Yeah, so I mean, I'm only basing it on the places I've worked, but most hospitals will now have they'll either call it rapid access chest pain clinic or low risk chest pain clinic, which isn't particularly low risk. It's for patients that you've got a suspicion of cardiac chest pain as the cause. So it's not just a catch-all chest pain clinic. It's when you think this might be coming from the heart, and you think it might be ischemic heart disease, actually, but you don't think it's the acute coronary syndromes that need admission now. So it's run by cardiologists, and normally someone going to the rapid clinic, you're saying they might have cardiac chest pain. I'm going to send them home with some GTN and aspirin, and then they'll be seen usually in 2 weeks, ideally, but I think our waiting list is even longer than that now. So that's where safety netting is really important, because if someone does develop worsening cardiac chest pain in that interim, they need to come back to ED.
Thanks, Jack. That's all for now in the questions, but I think definitely go on to some cases if you've got time to discuss a few.
Yeah, people are happy to stay. I mean, they're fairly quick, and should just reinforce the things I've gone over. I'm just reading that one question in the chat before I start. So how long do we spend taking detailed history despite visible observations that they may have a life-threatening condition? So that's one of the mainstays of proper emergency medicine. I mean, anyone who works in ED, you rarely see proper emergencies out of the couple of, I think we see anywhere from 300-400 a day. And there may only be 20, 30 managed in resus in a 24-hour period. So most patients are stable enough for you to take a history. But the whole point is that you're trying to get that history while investigating and treating all at the same time. So someone coming in hypotensive with chest pain, they're going to go straight into resus. They'll be on a monitor. The nurses will do the ECG. You'll do a gas. You'll get what history you can. You'll get a bedside chest x-ray immediately. You may put the probe on them straight away. And that's one of the real challenges, but one of the fun bits, if you want to do ED, is those type of patients that are actually having an emergency. So there's no definite answer, but you spend as much time as needed to work out what you need to do next. Let's go through these cases, because I don't want to take up all of your Monday evening, but thanks people for staying. I'm sorry we've gone over a bit. So if we start with a 62-year-old man, he's come in with central left-sided dull chest pain over the last 4 hours. Kind of varies a bit in how severe it was, and he said it did come on after lunch. He feels a bit sick. He's got some past medical history of high blood pressure and cholesterol and CKD, and he's on a couple of, he's on antihypertensive and statin. So if I can make this work, I think we begin with quite a tricky question. If I press start here, did the poll come up there? Maybe Eloise can help.
Yes, we had three coming up. So ECG question, ECG changes came as a question. What treatment would you give immediately? And then what investigations would be helpful? So those are the three questions up at the minute, and people are responding to those.
Lovely. I'll give that all a bit of time. Oh yeah, here we go. Sorry. So slightly, because I didn't, I've done all three. Let's say if you just answer the first question and then we'll discuss it before we move on to the second. Sorry for putting them all up. So I'm going to wait a couple of seconds, then we'll talk about the first one, then we'll move on to the second one. So which of the following ECG changes prompt immediate referral to a heart attack center? That's what they tend to be calling it these days. So somewhere where they can do PCI. And 69% have put ST elevation of 1.5 millimeters in 2, 3, and AVF. Well, it's gone to 71%. And that's the correct answer. So those of you that know your sort of territories, that's the inferior leads. And that's that's more than a millimeter in those leads is significant for a STEMI. Whereas ST elevation in V2 and V3, those are the two leads where you're allowed to have a bit more ST elevation before it is significant. And the top answer about the widespread ST elevation, that's seen in pericarditis. New right bundle is not a sign of a STEMI, but new left bundle is. And ST depression and T-wave inversion is seen in a non-STEMI, with the little caveat that you can get new ST depression in anterior leads if you've got a posterior STEMI, and then you can do leads, stickers on a patient's back and get a posterior ECG. But that's a slight little extra. The main answer here is ST elevation in the inferior leads, 2, 3, and AVF. But say this patient, I'm going to say the patient didn't have that. So I think on the next slide, he just had non-specific T-wave inversion, if that changes your thoughts. So question 2 is, what treatment would you start now? So you've taken the history, he's got this dull chest pain and a sort of non-specific, some inverted T waves on his ECG. I'll give you a couple more seconds. We've got 22 responses. And mostly, 59% have the right answer there. So 300 of aspirin there's good data that early aspirin improves like long-term outcomes in patients. So there's a real push for patients that come in with potentially cardiac chest pain, and he does have, T-wave inversion. He's got symptoms that sound like cardiac chest pain. He should get aspirin early. and GTN as causes sort of dilation of the coronaries, improves perfusion. So we would give him some spray really early on. GTN infusion you might use if the pain remains significant. Dual antiplatelets you would give for a STEMI if it's diagnosed, but we said he's not got a STEMI, or you'd give it for a non-STEMI, which will be diagnosed once we've got a TROP back. But at this stage, he's just got maybe some ischemic changes, but we don't know if those are long-standing. So he'd have some aspirin and GTN. And at this stage, what do we need to do next? So the answer here is a lab troponin. So I didn't mention in the talk about point of care troponins. Your hospital might well use them, but we use them as a rule-in test. So patients where you already have a high suspicion that actually this could be a STEMI and you want them just to go straight to the heart attack center, you might use a point of care to get an answer right there and then. In patients without a lot of ischemia on their ECG, they need to go through the more sort of rigorous process to rule it in or out with a lab trop. So he would get his aspirin and then he would wait for his actual lab trop result. Let's see if I can add the next poll in here. So my next question was, how would you further investigate if his troponin was chronically raised? So say it came back at 27 and you look back and it was always about that. What would you do next? I'll give you a few more seconds, the last few. Great. And so 61% of you have it right at the moment. So it was the third option down. So repeat in 3 hours, and you're looking for a 20% change to be significant between two trops. So the 10% is too close. And the top answer, not any raised troponin requires admission. So some people, like with kidney disease or cardiomyopathy, they might have a chronically raised troponin, and it doesn't mean they've got ACS needing admission right now. So if it's chronically raised, you want to do 2 3 hours apart, and you're looking for a 20% difference. And what is the most appropriate discharge plan for this patient? So I'm just going to flesh it out and say his pain resolves, his troponin was actually negative, and then you need to make a decision on whether he needs admission or discharge. And if he's being discharged, what is the discharge plan you'd make? Okay, last few seconds, people to pick. Right, and we'll answer that. So the plan, 55% of you have put the top answer. That's what I'd go for as well. So a patient like him we would use his heart score. I haven't worked out his exact score, but heart score is the one that takes into account the history, his ECG, his age, risk factors, and what his troponin was. And already just looking at his age, the fact he's got T-wave inversion, he's got some cardiac risk factors, he'd have a high score. So he should be referred to the rapid access chest pain clinic. And we would start anyone going to that clinic on low-dose aspirin and give them a GTN spray to use as required. So it's not dual antiplatelets at this stage. So it's just single-agent aspirin at 75 milligrams. Give him a GTN to use if he gets pain and refer to the chest pain clinic. Right, we've got 2 more patients. So our next one is a 34-year-old female who develops a right-sided sharp chest pain yesterday evening. She says worse if she takes a deep breath in, but she did have a bit of a viral illness last week. She was coughing a bit and had some clear sputum. So she's not sure if it's just that. No previous history, and her OBS are shown there. So my first question is, which of the following risk factors would most increase your suspicion of a PE? Great, I think most of you have answered. And yeah, 65% of you have got the right answer. So recent surgery has been shown to be one of the biggest risk factors. It's much more of a risk factor than the recent air travel, despite air travel being really well known as a risk factor. So yeah, 65% of you are right. If she's had recent surgery, that's a really, that would really raise your suspicion. And let's say we take a bit more history, and actually she had a ORIF of her ankle. So she had ankle surgery done 3 weeks ago, and she's not on anticoagulation. So what strategy are you going to use to get the diagnosis now? Okay, last few seconds. Yep, that's most of you. So the answer I was looking for, let's give it a sec. Check I know myself. Is immediate CTPA, which not everyone's put. So if I go through them, so the PERC score, she has to answer no to everything, has to have a score of 0 to rule out a PE. And already she's got a heart rate, she's tachycardic, which you may not remember off the top of your head, but that's one of the questions on the PERC score. So she's not PERC negative, she does score on that score, so you can't use it. So then the question is about whether you use a D-dimer or you go straight for a scan. And that's where you calculate her Wells score. And if the Wells score is high, so 4.5 or more, then she goes straight to a CTPA. And I haven't put up the calculation there, but the fact that she's had recent surgery and she's tachycardic, I can open it here, will give her a high score. So she would score at least 1.5 for her heart rate, and she scores 1.5 for her surgery. And then it's whether you think P is equally likely. So she'd get a score of 6 if you think P is likely. And that all comes down to a bit more nuance of of what you think is going on when you assess her, but someone who's got pleuritic chest pain, tachycardic, recent surgery, she should go straight for CTPA. And then one more question for her. So what other information do you need before you work out her treatment plan? Great, I'll give you the last few seconds to pick. Fine, a bit of a spread on this one. So the first thing I'll say is PESI score. PESI score is a PE severity index. So once you know someone's got a PE, that's a scoring system that takes in some of their parameters to work out how high risk they are. Then you use that with biomarkers, so troponin, to know if they've got cardiovascular dysfunction, and you use an echo to know if they've got right ventricular dysfunction. And it's the combination of those three will decide whether someone's got an intermediate risk or a low risk or a PE. So the top answer is the one, PESI score, their trop and their echo. Wells score is used in the diagnosis. That was a question before about working out, are they high risk or low risk, and do they need a D-dimer? D-dimer, yeah, again, is used in the diagnosis, and CRP we don't use as part of risk stratifying what treatment they need. And our last case is a 76-year-old man who's had severe central chest pain that started an hour ago. He's got hypertension and ischemic heart disease, and he's on a number of medications, and he's got the OBS shown there. So what are your initial priorities in managing this patient? Okay, I'll wait the last couple of seconds for people to choose. All right, that's good. So, yeah, about half of you got what I would put. It is one of those awkward sort of exam questions where there's lots of things you want to do, but really, clearly, he needs to go to resus. He's hypotensive with severe chest pain. It's still quite undifferentiated at this point, and he needs an ECG. Anyone with chest pain, apart from those who are very young and fit, who might be seen at urgent care, anyone like this needs an ECG. I would say those are the first two steps you need. I can see some people put about a full history, then CTA aorta, but actually you would do the ECG before you're taking his full history, because you'd probably want to do the ECG and do some resuscitation and see if he needs, fluids or any other kind of medication first before he can go through a CT scan. And you wouldn't launch straight into a full detailed history. So I would just get him into resus, and ECG is the first two. But obviously you are right that CTA aorta is probably what we're getting at. And then lastly, what features in the history would make dissection more likely? Great. 68% of you got it is all of the above. I mean, again, some of them have a bigger odds ratio. Some of them are more associated with dissection, but they're all well-known risk factors for aortic dissection. So the presence of any of those are associated with aortic dissection. And the very last question is, once he is stabilized, what is the gold standard investigation? Say he tells us, yes, it's severe central chest pain radiating through to the back, and he's got a blood pressure differential and this history of hypertension. What investigation does he need? Great. And I think 72% of people have gone for CT angiogram of his aorta. And that's what I was thinking as well. So I'm trying to describe someone here who's high suspicion of aortic dissection. A formal echo, we said that echo can be used as a rule-in test. There's some things you might see on a ultrasound. But a CT angio is the gold standard because it also will define all the anatomy. It will tell you whether it's a type A or type B, and it will help surgeons plan whatever they might need to do. Chest X-ray, we said, is also might show a widened mediastinum, but it's not going to do all that the CTA will do. CTPA is to investigate for a PE, and coronary percutaneous coronary angio is for investigating for ACS and looking at the coronaries. But here I'm thinking of someone who's got a aortic dissection.